Hello, hello, hello. This is Tooth Be Told, Dr. Kyle Dumpert.
This is Dr. Walter Aka, and we have a special guest, as you can see. Come on, man. You don't need an introduction. Just bring yourself in here.
Yes, sir. I am so excited to be back with my brothers from two different mothers. I've missed you guys. It's been a while, but I've been following a lot of your episodes.
Yeah, man.
And especially that great recession one and the hiring and all that stuff. That was a pretty good episode. Yeah.
Right, and it's funny because, I tried an experiment. I wanted to try to bring people to the YouTube version so they could see and watch the videos. It failed miserably because people kept calling me and asking me, hey, when do you put the next podcast up and so forth. So that failed miserably.
We're learning. We're learning.
Yeah. Going forward, I'm just going to keep it with both. Like I'll put it on podcasts and then I'll also put it on YouTube. But yeah, it was a big failure. But the reason why we brought you back on was because, we just wanted to, figure out how residency is treating you, right? The man who decided to go back for the plan, you know what I mean?
For those that don't recognize it, it's Dr. LeRoy Horton. If you don't recognize his voice.
He's been on enough. Oh yeah, he's been on enough podcasts. People need to start catching up here. But yeah,
Right.
So Dr. Horton, backstory: he was in private practice, had his own practice, and now is in residency for periodontics.
Mm-hmm.
So I wanted to kind of catch up with him and see how everything is going with that.
Yeah.
How he's acclimated, because I know initially it was tough. Right? It had to be tough. Going from private practice, doing what you wanted to do when you wanted to do it,
making money.
Now we try to not talk about money, so we don't sound like we're money hungry. But you're right, yeah. He had a paycheck coming in. Now he's basically probably paying somebody or getting a scholarship or something that's not equivalent to what he was making. So that's another story, right? So how has life been since you started? So it's almost a year now, almost.
Yeah, just about. We're partly into our last term for the first year. Mm-hmm. It's been quite a journey. I'll be honest with you. It's a mixed bag of positive and negative, right? So yes, I am making less money. Like technically, I'm in the red because of how much I'm paying in tuition. But I'm still working Saturdays, so I'm able to make a pretty good income. And the couple offices I work for actually have been doing a really good job at kind of stacking the deck when I'm there. So it's either implants all day or wisdom teeth all day. So it's kind of high production items.
Okay.
So overall, my cost of living for the most part is almost covered. And so I haven't had to dip into my bag of savings too much. And I decided to take out student loans for the first year to cover tuition and cost of living, just so I can gauge what my new costs would be before I decide coming out of pocket. And it's graduate level training, so the financial aid is always there if you want it, regardless of your income. But, so that took a little time to acclimate to, but I think I've found my zone as far as my little tiny studio apartment in Portland and driving back on the weekends to Tacoma, which is a 3-hour drive, and, seeing my kids as much as I can, which for the most part, they're all grown. My kids are 25, 18, and just turned 16. So,
so you had these kids when you were like 10.
When I was 10, yeah. We got fast. I told you I'm from Greece. In Greece, we move fast.
You got to make sure people know that.
Right. But I think one of the difficulties I've run into, and both of you can probably attest to it, is the culture in academia can be a little challenging when you're coming from private practice. In private practice, it's all about, if you need something done, you get it done. It's about efficiency. Academia has a lot of red tape and processes. There's a fair amount of ego, and perio especially is a very... So we've always made fun of oral surgeons for being like the jocks, like the real arrogant, cocky jocks, the high school football player.
Yeah.
I liken perio to the kids who were kind of the nerdy outcasts who now have an opportunity to like shit on residents and students because there's don't get me wrong. There's a number of faculty members that I love. They're very helpful. They treat you like a colleague. And there's other ones that just seem, there's an air of just self-aggrandizing, a lot of self-aggrandizing that goes on. Luckily for me, I'm at the age where if I have a bad day or if, a faculty member is being a little condescending towards me, like, to me, it doesn't make or break my identity because I'm older, I'm established, I've done shit. I know that I'm a pretty kick-ass clinician overall, whether or not I did well on this test or I answered the question the way you wanted me to answer it. But I feel bad for some of my co-residents who are in their, mid to late 20s and they really don't have an identity because they've been a professional student all their life. And you just see how it affects them. Stress affects them. And so I don't like that because I feel like my job, if I was an educator, is to inspire, is to educate, and is to do whatever it takes on my end to make you proficient, competent, knowledgeable. Whereas in academia, there's a lot, especially in graduate level training, a large part of it is like an expensive self-study course. You know what I mean? So
notice I'm not saying anything. I 100% agree with everything you're saying. I'm not. This is your story, so I'm gonna keep quiet.
Now you were doing some pretty high level stuff before you went back into perio, where most perio residents they're able to start with or the instructors are able to start with a blank slate as far as teaching them this is the first time you're ever doing a gingival graft surgery or first time doing implants and you've been doing a lot of that stuff at a pretty high level before residency.
Yeah, in all honesty, you were doing stuff that we did in third year, our final year of surgery residency. You were doing that in private practice. So then, to me, I remember thinking to myself, like, why the hell is this guy going back to school? Seriously, no, I really did. I was like, I don't get it. Like, does he want to do prophies and SRPs? And like, I didn't understand. And then from both, it's like, you go from like doing like jaw surgery to now doing like cleanings.
Yeah.
Your first semester, but to a demo student who just got into the residency, that's normal transition.
Yes.
Right. So you've done that. So now you're transitioning to more cleaning. Then you progressively get more and more into the technical stuff, into the more advanced surgeries.
Right.
You were doing the advanced surgery stuff already. So, I mean, to me, I would have thought you would have went backwards because that's how I was when I did 1 year at the VA hospital. I felt like I was going backwards.
Right.
So I can only imagine how you felt.
That took a little getting used to because, yes, my first 6 months, especially because the way the program works, other programs, you could do limited exams, limited care. And so some of my buddies, like at the University of Washington program, they've done some stuff that I haven't done yet in my program as limited treatment. This program's philosophy is you cultivate your own patients. So everything starts with a comprehensive exam. You got to get them through initial therapy, get them primed and ready for the surgeries that you've planned and so forth, which I can see the benefits of both, right? I haven't complained too much because I have had more time to focus on the didactics and the research, which was kind of one of the main reasons I went to it to begin with. But also because I work on Saturdays, things that I'm learning that I haven't quite done in residency clinicals, I'm doing every Saturday when I work. And so I don't feel like I've backslid too much because I'm still active. I'm still doing plenty of implants, plenty of surgery, sinus lifts once a week, whether or not I'm quite there in building up my patient caseload in residency. But absolutely, and I think that for me, it was a good exercise in humbling myself, right? Because as advanced as I was clinically, there was huge gaps in my knowledge that, I even realized that I had even bigger gaps as I started learning, right? Now, mind you, some of that is perio is really big on knowing the history of everything, right? So we're having to memorize and being tested on, articles from the 60s and 50s, some of which have been updated and are outdated and no longer relevant. But it's, it's part of learning the science, the curriculum of it. And
we call that classic lit. Classic
Yes.
literature.
Yes. Very classic.
You have to give everything a name. Classic literature.
Very classic.
Yes.
But also what you realize with classic literature is a lot of it was based on, Norwegian and Nordic or predominantly white populations. And at least some of our faculty members that are from more, diverse ethnic background, they do a pretty good job of acknowledging, like, hey, take this with a grain of salt because this is not a very representative population, even though it was a landmark study, because we know the world is very big. It's bigger than Sweden,
Right.
But yeah, I'm enjoying the process so far, but I really had to learn to humble myself and, yes, sir, no, ma'am, or yes, sir, yes, ma'am, to pretty much everything, even if I disagree with it. Because as both of you have probably seen in academia, a lot of professors feel like the way they learned it and the way they teach it is how everyone does it. And you just have to remind them, like, well, we kind of learned it different, but you're the boss. So while I'm here, I'll do it your way.
Right.
So yeah, I think that's the biggest part is I really had to go in and humble myself and, not try and walk in like, an experienced rock star. And in doing so, I did realize how many holes I had in my game. So I do appreciate the stuff that I am learning. And I definitely can't wait until I get into second and third year and my caseload really builds up and I'm doing the more advanced, especially the soft tissue perio stuff. Because I think that's where a lot of my game was lacking was the soft tissue.
Yeah. And here's a question for you. Did you find that a lot of your professors and a lot of stuff in academia were very much of a hero mentality? Like, we need to save this tooth at no matter what cost. Because I remember going through residency and thinking, like, man, we're saving this tooth? Okay, let's do it. Like, teeth were moving. Literally, you could blow on it and it was like, hey. And it was like, all right, cool. Let's try to figure out how we can keep this tooth in this mouth. And as much as I believe that that's what perio is, periodontics is basically trying to work with the bone and the soft tissue and everything to try to keep everything the way it is. Sometimes you just have to say that's a lost cause, right? But I felt like in residency, we weren't saying that as much.
It depends. The career academics, definitely, they want to see, well, let's do initial therapy and let's do maintenances for 2 years and see if we can get these class 3 mobilities to firm up. Whereas a lot of the affiliate faculty, and I think in dental school was pretty similar where the clinical faculty that were there, 1 day a week, 2 days a week, they're concerned about, all right, what can we do that's definitive? The patient has money now, patient has insurance coverage now, they may not have it for 2 years. What's the thing that we know for sure we can do to get them to this point, right? And so it is one of the struggles I have is I'll do an initial workup with a faculty member that's a private practice that's there, once a week, once a month, and they have that, let's find some definitive treatment for this patient. But then the patient will get scheduled on a day that the attending faculty is, more of a career academic. And then they're looking at you like, why are you doing surgery? Why aren't you doing it? You know what I mean? Why don't you do maintenance and then, monitor for 6 months and see what happens? And you're just, I'm just like, I'm just doing what I was told.
You're stuck in between.
I'm stuck in between. But definitely, I don't think I'm going to have that mentality when I get out because I'm still very much private practice driven in that I do have to take into account what the patient's history is, what their means are, where they might be 2 years from now. And patients also do want some expediency. If they come in and, there's a couple teeth that they've been told several times need to come out, who am I to say, all right, you want something done within the next 2 months, but I'm going to talk you into a year worth of waiting to see what we can save, what we can potentially keep. And so you kind of have to develop your own practice philosophy. And I don't think I'm sold on the ultra heroics. But I'm also not the other way where I just, want to yank teeth all day and place implants because there's complications with implants that,
Okay, so you just basically did a great transition.
That was,
right? It was, because what I'm thinking is, I'm sure Colin knows this, but there's this new group of dentists, new group of clinicians, new group of whoever that believe that we got to take teeth out. If you had root canal and it failed, you just got to take it out and place an implant. Like, everybody's big on all on fours. Like, I get patients asking me all the time, hey, what happened to, those teeth in a day situation? Yeah. And I'm always just like, well, yeah, it's a temporary tooth. It's not the permanent tooth. But no one ever says that.
Right.
Right? They did it. I mean, they've done great marketing. And I mean, I'm not going to say any names, but they've done great marketing to make it seem like you literally taking out your teeth means nothing.
Right.
Cutting all that bone away means nothing. Imagine if you went to your doctor and you had a wart or like a pimple, and they're like, yeah, that arm has to go. Yeah. That's what we're doing, I feel like. It's like, oh, well, I have a pimple here. Well, that jaw needs to go now. Yeah. You know what I mean? Like, we decide one little problem needs to basically be exacerbated towards the whole entire mouth. And
they think that losing I've had people the same that have every tooth in their mouth. And I mean, they've had some restorative work done. They've had crowns and I just want to get all my teeth out and get implants. And they think it's going to be better than what they have. And no, if you can't take care of real teeth, it's a lot harder to take care of a bridge that's sitting on top of 4 or 6 implants and getting in underneath things, cleaning your ham sandwich out. It's a lot harder to take care of that stuff than just maintaining your own teeth. So you're right. They've done a great job of marketing this as this is the best of the best that you can do to yourself.
Well, but then whose fault is that? Is it the dentist, the patient, insurance? Like, who is responsible for this, where we're at right now, right? Because I think, and you guys are all in the same, you remember when sleep apnea was the big thing, right? Then Invisalign, then it was veneers, right? And I remember composite, I'm dating myself, but composite veneers were hot when I was first going through dental school, right? Everybody was an aesthetic dentist, everybody. My grandmother's an aesthetic dentist. It was like Oprah, like, hey, you're an aesthetic dentist. And, then it became sleep apnea. Now it's implantologist. Everybody's an implantologist without even knowing how to do the basics, which is taking a tooth out. Yeah. But everybody wants to do full mouth rehabs. And I was watching a lecture series, and the guy basically started off on a rant. He got mad. And it was like, not everybody just needs to do this. This is ridiculous. And I'm sitting here like, he's angry. He is angry. But I felt that anger, though. I did. I felt that anger because that's what I've been thinking for a long time. But when I say it, I'm that specialist that just doesn't want general dentists to do surgery. And I'm like, no, I don't care what you do. But you got to at least know what you're doing. Right. So who's responsible, guys?
I think it's kind of a systemic failure of a profit-driven healthcare system, right? Because we're not as driven by positive outcomes as we are profitability. And you can't really just put that on the shoulders of the dentist, because the dentist is operating within a system where they got $400,000 or $500,000 worth of school debt, right? The industry has, sold them this bill of goods that, to be a good dentist, you also have to be a mogul, an entrepreneur, multi-practice owner. And we're also living in a society where you kind of your value is measured by your financial gain over time, right? So even when I'm talking with my classmates, in the conversation is always, lauding who owns the most offices, who has done the most. And, maybe I'm just at the age where, with life experiences have a slightly different perspective on life, but that kind of stuff means nothing to me. If you can own 10 offices, but if you don't have quality time with your kids, what are you doing with your life? You can be a millionaire multi times over, but that doesn't mean that you're putting out quality work. That doesn't mean that you're not potentially taking advantage of employees or overdiagnosing patients so you can make that that extra profit. And there's a gray zone on overdiagnosing and underdiagnosing, but I feel like it's just the system as a whole. Then you bring in the educational system, the private education system, right? The CE courses, the continuums, the labs who come to you and say, don't worry, we got you. We've got this denturist. We'll scan the case. We'll design it. You'll take all the teeth out, put the implants in the same day. We've got your prosthesis. And you got doctors that are jumping from 0 to all on X cases with no gradual, kind of ramp up in their education and their experience. And I think there's going to be a huge blowback when a lot of these complications, I mean, even now, peri-implantitis over the last 5 years has been the buzzword of every major implant conference. Because all of a sudden we were taught in my day that, oh yeah, once you got an implant, you got that implant for life. And now you people are realizing, not quite so much, And one of the things, so I Dental Town reached out to me for another CE article. And so the one I ended up writing was from the perspective of a lot of stuff that I've been learning in perio as far as risk assessment. Mm-hmm. And that's something I felt I wasn't taught as a GP that was doing like a hodgepodge of continuing education courses. Mm-hmm. Is, I coined it as, being an actuary when it comes to the tooth that you're thinking about taking out or replacing, right? Why did this person lose this tooth? Oh, it was bone loss. Well, why did they have bone loss? Oh, they got periodontal disease. Why do they have periodontal disease? Is it poor oral hygiene? Is it diabetes? Is it, And so we do very little risk assessment. All we see and all we learn, especially as a GP, is in a lot of our courses, you got a missing tooth, implant. You got a broken tooth, take it out, implant. But you're not looking at the big picture. And a lot of dentists are having implants come back with complications, with bone loss, with inflammation, because they weren't assessing the patient's risk. And I'm showing up to offices where I'm doing consultations because the GP wants me to put an implant where the tooth is missing, but they got 7-8 millimeter pockets everywhere. They clearly don't brush their teeth. And so I'm having to have a conversation with the GP like, hey, I don't mind doing the consultations, but you got to do the legwork. Like the fact that this patient has been under your care for, 6-7 years, you maybe did scaling and root planing 5 years ago, but you got them on a 6-month prophy. Like you need to either make the appropriate referrals or you need to do oral hygiene instruction. You let them know, hey, if you want to implant, that's the reward. The work you got to put in is I need you to come back and you need to start brushing your teeth and you need to show me you can be compliant with that. So there's so much big picture that's missed, Well,
what I'm gonna push back and ask you for your input when I do this, but I a lot of the stuff that I hear is, well, insurance kind of dictates a lot too, or patients dictate, right? Mm-hmm. I've had patients come to me after, they're like, hey, I want an implant, like you said. And I'm like, well, you got periodontal disease. We got to take care of that first. And their eagerness to just move on to the final product, which is the implant and crown. Then they go, oh, well, I don't have time for that. And they'll go somewhere else. And I can guarantee you they'll get it. Yeah. No, I'm serious. And then I'll guarantee you they'll get it. And for me, I'm like, well, if the second I do anything on you, I have to be responsible for that whole entire situation. Mm-hmm. And then I'll also talk to general dentists who don't do occlusal evaluation to check, can an implant go here without taking on all the forces that it can take on, right? Like that's something that, to me, we had to read about, learn about. And so I'm almost a bit of a coward when it comes to, malocclusion. Like, I'm like, no, this is not perfect. This is not close to me. This is not even good. Like, we need to figure out what we need to go through braces or whatever it may be first. But that's not the mindset a lot of people have. So how do you talk to a referring dentist without basically pissing them off and thinking, well, every time I send you a patient, you say, no, they need this, this, and this. Because they're thinking, oh, you just want to make more money. And patients are probably thinking, you just want to make more money. Right? But in actuality, you're the only one that's actually doing a thorough job. I mean, Kyle, what do you think?
Yeah, I think they're dealing with the patient. I mean, we have to respect the patient autonomy, but we also have to respect the do no harm. So balancing those two things, where if we're going over the risks, if somebody has,
Kyle,
yeah,
go back and say what you were just saying, because I think you were kind of coming in and out.
So I was saying we have to respect patient autonomy for them being able to choose what kind of treatments they want performed on themselves. We also have to respect the whole do no harm to the patient. So If somebody has a full mouth of perfect teeth, we're doing harm to that person by taking out all their teeth and putting implants in.
Right.
If somebody has traumatic occlusion, bruxism, clenching, and they've broken 3 or 4 teeth, split them in half, and we're trying to replace it with 1 or 2 implants, when the occlusion and that parafunction is potentially going to cause the same issue with the implants, where is that line that we draw of letting the patient know the risk? This is the risk of, or there is a risk that you might have some problems with these implants. Same with if you have a history of periodontal disease, there's a risk that you're going to get periodontal disease around these implants too if I put them in there, if you don't take care of them. So
so what do you do?
Right. There's a big gray area, like you said, of what is considered good treatment. How much responsibility do we give to the patient to say, you have to take care of this, you have to do what I say, otherwise it's not going to work out for you. And I think that's something all of medicine handles. If you're going to get your heart or a heart transplant because you didn't take care of yourself and you continue to eat poor quality foods, you're going to run into the same issue again. But is it the doctor's responsibility to say, you know what, you didn't take care of it, I'm not going to give you a heart so you can keep living?
But Kyle, I'll be honest with you, man. I feel like medicine is a little more strict than we are, man. Like, I know these doctors, literally these cardiologists that I work with and deal with, will not do anything on the patient unless they've gone through this list of stuff that needs to be damn near perfect,
right,
before they will do any, you know what I mean? Because they expect that what they do should hopefully last a substantial amount of time.
Right.
But with us, it's just kind of like, what does the patient want? Okay. So I feel like just overall dentistry has gone to the left of, almost being like a Chick-fil-A. I use Chick-fil-A as an example because the service is incredible. The service is incredible. You know what I mean? But we're not serving just fries. We're trying to serve good dentistry. So we can't just cater to patients and all their whims. Because if that was the case, we would have people going around with like porcelain white, toilet looking teeth. You know what I mean? But sometimes we gotta step in and say, guys, this doesn't look normal.
Right.
How about we try this? How about we try that? So I think we've swung too far. Where we think patients are the ones that are dictating treatment. And I feel like a lot of doctors are like, whatever, I'll just do whatever the patient wants me to do, good or bad. And that's my opinion. I'll speak on that. I'll just say that's my opinion. I think a lot of people have I'm serious. A lot of people have swung way too far. Way too far, where I'm like, this tooth could be saved. And they're like, nope, this tooth needs to come out. Or this tooth, needs to come out. And they're like, well, the patient doesn't want it out. It's flapping in the wind. Yeah, the patient's not ready for it to come out yet. But can you put an implant next to it? No, I cannot do that. So it's almost like damned if you do, damned if you don't. You know what I mean?
No, I agree. And I think, Kyle, I like your input, and me having been a GP for so long, there's a lot of pressures on us, especially on the patient demand front. Yeah. It could be as simple as, tooth is broken down, needs a root canal and a crown, patient can't afford it.
Right.
Are we going to most of us probably deem that as a reasonable justification for a treatment that we wouldn't otherwise want to do, because we wouldn't, if it's savable, we wouldn't want to take it out. But if they can't afford the root canal or crown, what are we supposed to do? Right. And then you have patients where even if they can't afford it, their value system, growing up, my mom had dentures, my dad had dentures, grandma had dentures. Yes. I'm not going to put $2,000 in the tooth. Right. That's a month's rent, or that's my new. Out here in Washington, that's my new hunting rifle. With
that's right.
Scope.
Kyle, we're about the same, right? Let's not pretend, Kyle. I've seen people with better cars than I do, and I'm like, with no teeth. And I'm like, I see
that's what they value.
I see that. It's okay.
Yeah, so I think it's incumbent on all of us to find our individual lane within the spectrum of do no harm.
Mm.
But I think as an industry, it's gone so much towards the profit motive, because we're all driven by profit to a certain extent, whether it's paying off our loans, whether it's paying off, our rent every month, if we're, an entrepreneur and we got our own business. A lot of us have been in school so long, we're starting to make a decent income in our late 20s, early 30s, and we've got to kind of make up for that time with our family, with our wives, with our kids. So I think money in this is kind of the root of all evil, and I not to become overly, religious.
You just transitioned. Another great transition. Keep going. I'm gonna bring something else.
I really wish that there was either higher reimbursements in general from insurance companies, right?
No. No, come on. We're come on. They treat us good.
I wish there was a structured way of reimbursing positive outcomes, and preventative medicine or dentistry.
That's not the American way, though.
It's not, and
listen. Don't be communist on us. It's not a communist podcast. This is not a socialist podcast. You will
but I'll tell you a good story. So my uncle in Greece is a cardiologist and a pathologist, which kind of translates to like a general doctor, right? But he's also a cardiologist. And when I first got into, graduated, was in the profession, started owning offices, and I acquired my second office, we were sitting down one day on one of my trips back, and he was like, "So you own 2 offices now?" And I was like, "Yeah." He was like, "Well, how do you see all these patients?" I was like, "Well, I got associates that work for me." And he was like, "But they come to see you, And I was like, "Yeah, but I mean, I'm trying to run a business. I'm trying to, be a mogul and all that kind of stuff." And he was just like, "But you're a dentist." Like it was very foreign to him, because, mind you, he is your quintessential old school doctor. Little black bag. He has his one little office where he sees patients, still gets calls at like midnight and goes and makes house calls to people's homes privately. Like, he is doctor through and through. And for him, and just the culture there, especially at the time, he couldn't fathom why anybody would want to like outsource out your patients to associates, and the whole business aspect of it. Like, he just thought America had made me crazy. And
it probably has.
It probably has. But wouldn't it be nice if you could just make a decent living and truly be concerned just about patient outcomes and not necessarily what your overall production was every month? That would be nice. Not possible in our system, but I would love to get back to that.
Isn't that happening? Dr. Strive for Great Health, Dr. He's a functional medicine doctor.
The guy in Florida?
No, he's in Texas. Functional medicine. He was pharmacy and medicine.
Dr. Harris.
Yeah, Dr. Harris. I think that's the model that functional medicine doctors are following, where it's kind of like concierge doctor. You pay us a monthly fee or a yearly fee or whatever, and we're focused on the outcome, not on what services we're actually providing.
Right.
So it would be nice to see that in dentistry as well, because I think we all know that the tooth that lasts the longest in anybody's mouth is the tooth that doesn't get touched by the dentist. As soon as we start touching it and working on it, it starts that whole process of your filling turns from a filling to a four-surface to filling to a crown to a root canal and crown to crown elongation to extraction. And if we don't touch the tooth, it has a better chance of staying in the mouth longer, right?
That's the Ziv Simon money tooth. Yeah, good.
And I tell patients that all the time. Yeah. When I'm trying, I want you to brush your teeth. I want you to use fluoride. I want you to prevent these incipient cavities from turning into fillings, because once I do a filling in your mouth, it starts a whole process. Nothing I do is going to last forever. And as soon as I touch this tooth, it's got an end date on it at some point.
That's actually very, very true. Let's transition real quick, and this will be the last topic. There is a stigma, or there's, I guess, a rumor out there, and I've talked to people that believe this, that in private practice, the doctors don't care about the bottom line at all, really. They're just there to basically work and enjoy life, and they don't care about profitability. But corporations are the greedy, big ones that only care about numbers and not people. And I'm going to basically say that that's a lie. It used to be that way. I felt like, when you had your own practice, you were like, hey, we're a small family. But more and more people are taking these courses that say, how do I think like a corporation? How do I, like you said, get the multiple practices and become a DSO or become this conglomerate? You know what I mean? So the American dream of capitalism is, I think, very much alive in everybody. Maybe some people are doing a better job of hiding it, but I honestly believe, like you said, Dr. Horton, that where do you balance out greed, insurance, and wanting to grow as a capitalist, as a business person, right? How do we balance all that out? And I think before, when we did the Great Resignation, and by the way, you guys should all check out YouTube, because it's all on YouTube.
How do they find you on YouTube?
Say what?
How do they find us on YouTube, Walter?
It's very, very simple. It's Truth Be Told podcast. Very simple. We kept it very, very simple for everybody. But anyway, I felt miserably, but I digress. But no, honestly, how do we make sure that we don't lose the mom and pop feel that, like you talked about with your uncle, and because what he said is actually very true, man. Like you're confused because when they see your name or they hear about your name, they don't hear about your associate's name. They hear about your name. But yeah, we're basically punting off all the work to our associates or other people when they came to see you. And patients, I know, get frustrated with seeing a different doctor every time. Because let's be real, associates aren't lasting like they used to.
Right.
No.
Right? So we're in this situation where people aren't lasting like they used to. Doctors don't want to really do work because they're thinking about retirement before they even touch a tooth. Right? And everybody's looking at Instagram and saying, I want to be like that doctor, but they don't know how far or how long it took to get to that point. Right? But we're all supposed to be riding in like private jets and so forth. Like, how do we come back to reality?
You got a private jet?
I sold it too. I sold it yesterday.
You sold it, okay.
I said it's time for me to be humble.
Gas prices were too high.
That's actually what it was. It was like, you know what? It's millions of dollars to maintain. I said, I'm tired of this. Let me just stick to my Lambo and Lamborghini and my kids, being Rhodes Scholars. I'm going to be happy with that. My 4 and 2-year-old being Rhodes Scholars. But yeah, no, man. But how do we get back to reality? And I think we're lost. I think dentistry is lost, and we need to get back to reality. How do we do that?
Well, I think one of the things that I don't think we can ever get back to that because the corporate model has kind of overtaken everything, and now the small mom and pop places have to compete with the corporate models. Because they're opening up all around us, and so
it's like Walmart. Walmart.
It's okay. Putting all the private, grocery stores out of business. Every time a Walmart pops up, there's like 40 businesses that go under, right? And so Washington State does have a law saying that to own a practice, you have to be a licensed dentist. But they got around that, right? You got investment firm money that finds one dentist and puts everything in his or her name. So now they got 60 offices in Washington that's under their name. And so I'm very pessimistic about what the culture is going to look like for the next generation. Because I'm literally talking to these dental students who just off undergrad and dental school are having 2 or 3 times as much debt as I had. Mm-hmm. They're not necessarily being compensated much better. Their skill set isn't much better coming out to where they can command larger, and we all know the moniker that Walter likes to use for new graduates, especially in the COVID era, right? But
listen, tell me if I was wrong. Tell me if I was wrong.
You're not wrong.
And it's not their fault. It's just that they didn't learn anything.
They didn't, and then you got schools that are increasing class sizing, increasing tuition because they know that the financial aid market is going to give them whatever. If it's $200,000 a year next year, government's going to give that, and it's going to be a guaranteed loan that you can't get rid of, even with the bankruptcy. So I feel like the deck is stacked against not only dentists but against the profession as a whole. And the culture until it is really just one big, investment algorithm that dictates everything that we do.
It's amazing you say that because I know there are a lot of money coming into dentistry.
Yeah.
A lot of private equity money coming into dentistry, man. Like, it's kind of like the housing market right now, right? I was reading an article, was it last night or this morning, that was talking about the housing market and basically how difficult it is for new homeowners to find a house, to the point where they're just giving up. They're like, I actually like bid 20,000, 30, 40,000 over ask, and I'm still not getting it because there are people that have all cash offers, no contingencies or anything. And that's where I think dentistry is going. And in all honesty, I feel like dentists are also selling to those because they're like, oh, I'll get more money for my practice versus somebody like myself that comes in and says, hey, let me look at your books, do all this extra stuff, and say, oh, well, no, your office is actually valued at this amount.
Right.
Maybe private equity might say, nah, hey, give them, an extra 200,000 more. Who cares? We'll turn it around. We'll make the money back.
Right.
You know what I mean? And that's what's happening, I think.
As the optimist, as the forever optimist.
That's a lot.
What is the what is the benefit of this private equity money coming in, DSOs or other these smaller DSOs? But one of the benefit I see there is most dentists have no experience with business, how to run a business effectively. We are in a very forgiving industry where we can be a terrible business person and still make a pretty good living for ourselves. And I think a lot of the dental companies have taken advantage of that. The Henry Scheins, the Pattersons, the any other Kerr or any supplier. I mean, what they can make bonding agent for and what they sell it for. I mean, it costs them pennies to make a bonding agent, but they're selling it at like it works out to either $500 or a couple $1,000s per gallon for. I mean, we're not buying it by the gallon, but that's what it equates to. And I mean, for the technician to come into your office and they charge $160, $200 per hour to work on your stuff while you're there, and we just pay it because we're not business people, we're kind of stuck in that where DSOs, private equity money, business people coming into our field, it's forcing these suppliers to like, no, I guess we can't really take advantage because there's more buying power. They're still taking advantage of the small single loan offices, but there's a portion of them that are, especially the DSOs, they're not able to take advantage quite as much. And that's starting to trickle down through different, there's a, I've mentioned Fortune Management as a consulting group that I use, but they work with a new company called True Blue, where it gives you that DSO buying power, those DSO discounts, because they manage enough offices that they can help out the independent dentist by signing up for these co-ops or other things. So that model is trickling down where it can help the independent dentist get those same kind of discounts and same business benefits that we should be entitled to.
Well, here's a question, Kyle, and the same goes for you, LeRoy. So just like with anything, right? And I learned this when COVID happened, when we went through this whole, supply chain issue, right? Companies are very, very smart, right? They're billions of dollars. They're making billions of dollars, so they're very, very smart. So if you think that they're not going to cut costs, cut corners, make a product that's less inferior, more inferior than what you previously had, and just to save money, you're kidding yourself. So maybe that bonding agent that maybe lasted 6 months, the shelf now only lasts 3 months. Oh, because you think we're going to negotiate with us. Cool, that's fine. Negotiate all you want, but we're just going to give you something that you're going to need to come back to us 3 months later versus 6 months later, because the stuff has expired. So that's going to happen, right? So what do we accomplish in the end? Besides, we've lost our autonomy. What else did you accomplish?
That negativity water, it just, I choose to look at the positive. The free market, if you're buying something that doesn't work, I can go to a different company, and somebody's going to want to put out a good product that is going to have repeat customers.
That's if you are willing to take the time to understand the product you're purchasing.
Right.
That goes back to a lot of dentists not even knowing what they're buying. They just know that some guy, some guru recommended it.
Right.
We basically become Instagram. Some influencer recommended something to you to buy it.
And you got to remember, you got to remember that a free market is predicated on there not being the amount of consolidation that we have currently in our system. So now you have, Dentsply buying up all its small competitors. You have Henry Schein buying up its small competitors. And so, although in an ideal world, true free market, you could theoretically say that there would be someone that puts a better product at a reasonable price, but we're seeing monopolies across the board. We're seeing monopolies on insurance companies, manufacturing companies, distribution companies, and so you're really limited on what you can, and especially when you see, for instance, you'll have a company that puts out a product that, patents are starting to run out. Well, they'll start lobbying to make policy change to make a new FDA approval of a competing product more expensive, more difficult. You see that with insurance companies, right? So the major insurance companies, especially here in Washington, were lobbying for policy to make any new startup insurance have to have a larger percentage of liquid assets, right? Which made it impossible for new insurance companies to start up. But if you're already established, you can maintain that higher liquidity because you've been there. You understand what I'm saying?
I agree,
So I think in all what ends up happening is they're just gradually assimilating us into this perpetual system of, money trickling up, not really trickling down, but money trickling up to the, the big companies and big corporations, the more and more that they consolidate.
Let's wrap it up here. We're depressed now.
Yeah, I'm not. There goes my optimism.
That lasted like 5 seconds.
We'll all move to Cuba or something. And
I'll come pick you guys up with my private jet. Let me know when you guys are ready. But no, this I think this had to happen. This had to, we had to have a conversation because I'm seeing this happen again. And I know this podcast is big on let's just talk about what we're seeing. Let's talk about what we're seeing going on in dentistry and how we can either solve it, bitch about it, or just let it go, or find solutions to it. So that's what we're doing right now. We'll come back and then we'll keep doing this and we'll figure out what we need to do. We'll figure out what we need to do. But thank you, Dr. Horton. I really appreciate you taking the time.
Thank you for the invite. I missed you guys. We got to do this a bit more often.
Yeah, man.
Absolutely.
Whenever you want. And did you? Can you send us that link so that people can actually read that article you wrote?
I'll send it. It's supposed to be in the June issue, but he's trying to push it out for the May issue. Cool. So as soon as that article comes out, I'll send you the link, or in a month or two, if we do another session, we'll talk about it. So
you are always welcome on here, man. You're always welcome.
And also, I'm going to be lecturing and teaching a hands-on portion at the NDA convention in Arizona in July.
Oh.
So if you or anyone else that is interested in, there's going to be a couple pretty good lecturers on that card. And it's in beautiful Arizona at can't remember the name of the resort, so I can't give it a plug. But just go to ndaonline.org or .com.
Okay, and what part of Arizona?
Phoenix.
Phoenix.
Okay.
Phoenix.
Nice. If you're a golfer, you can always go out there and at least enjoy that too. I've been to Phoenix. I've been to Tucson. It's a good place to go. In the summertime.
It's like 110, 115.
Right. But winter's beautiful.
Yes.
But no, absolutely. We'll definitely give us a link and we'll put it on there on the show notes and we'll go from there.
Awesome. All right, fellas. Great talking to you.
You too.
Excellent. Thank you, guys.